Yeah, now I think we're fine.
Yeah, you're back.
So my thinking is, we struggled so much to learn about resistance and identify resistance mechanism, we did not succeed. So I wonder whether we're in the same place, with resistance to immune checkpoint inhibition, that we build a lot of ideas and so, but we'll see whether we succeed. I hope so we do. So, do you want to introduce the first speaker?
Yes, of course. It will be a pleasure. Good morning, everyone. Allow me to thank Delvis for this amazing invitation, and just to say, as we all say, and we all tweet, how proud we all are to be part of this amazing family. It's a pleasure and a privilege to co-chair with Rolf, that I know for so many years. And it's also a huge privilege for me to introduce the first speaker. And of course, I'm a bit biased, because he's from Greece. But not only that, he's one of my best friends. He's one of my mates. He's my partner in the thoracic oncology journey in my country. And as you all know, he's one of the pioneers in thoracic oncology internationally, and one that has been tirelessly working over the years to bring more and more clinical studies in a small country. And I think I can proudly say that he's one of the people that have managed to put Greece in the oncology global map. So, Yannis Mougios. And as you know, he's a wonderful speaker.
No.
Thank you no doubt.
No, please.
So
thank you so
forward.
much, Elena, for these kind words. You are certainly biased towards me. And thank you, Mr. Chair, for this honoring introduction, very kind introduction. And good morning, everybody. It is a great pleasure and honor for me to be here today with all of you in this beautiful place. A special thanks goes, of course, to Charo, to Stephen, to Louis, and certainly to Delvis for your magnificent hospitality. Thank you so much. So, breaking the limits and redefining boundaries is certainly a very ambitious title for small cell lung cancer, but I will do my best. These are my disclosures. And you all know the clinical course of small cell lung cancer, starting with initial chemosensitivity, rapid and fast responses. I don't know whether that works or not. But anyway, sorry. It's okay. It starts with fast and deep responses, unfortunately followed by fast emergence of resistance, and then quick relapses, early relapses, poor responses to second-line chemotherapy, usually monochemotherapy, leading, unfortunately, to death within approximately 1 year after initial diagnosis of extensive-stage small cell lung cancer. And of course, the big question here is, how can we change this natural course, this curve of small cell lung cancer? And to do that, we first need to take a step back to the molecular biology of the disease and remember that there are two main driver genetic events that drive neoplastic transformation in small cell lung cancer. First, you have complete knockout in the vast majority of cases of the two main cell cycle regulating tumor suppressor genes, TP53 and RB1, leading to uncontrolled cell proliferation. And secondly, you have deregulation of the Notch1 pathway, which regulates cell adhesion and mobility, and this coupled with increased transcription of neuroendocrine factors like the ASCL1, mediate epithelial to mesenchymal transition, leading to chemoresistance and early relapses. In fact, we should see small cell lung cancer as a spectrum of disease. On the one edge of the spectrum, you have the so-called more neuroendocrine phenotypes, which are characterized by increased transcription of neuroendocrine factors, leading to biological aggressiveness of the tumor. And you have there subtypes like A, N, and YAP1, if we consider YAP1 a separate type, because YAP1 is also expressed in other molecular subtypes. And on the other hand, on the other side of the spectrum, you have the less neuroendocrine phenotypes that tend to be more they have an intact Notch1 pathway, less transcriptional neuroendocrine factors, and of course the famous immune-inflamed phenotype belongs to this side of the spectrum, and it's those patients that have been shown to have the best prognosis in both the IMpower 133 and Caspian trials in the first-line setting. So this is a delicate balance between neuroendocrine transcription factors like ASCL1, which synergizes with DLL3 to mediate those neuroendocrine differentiation, and on the other hand, ASCL1 suppresses DLL3, and DLL3 suppresses Notch, which on the other hand, the suppression of Notch leads to a more neuroendocrine and more biologically aggressive phenotype. And this renders DLL3 an appealing therapeutic target in small cell lung cancer. This brings us to T-cell engagers. You're all aware of this new class of agents for small cell lung cancer. Tarlatamab has been the first one, a bispecific T-cell engager, binding to both the TCR and DLL3 surface biomarker of small cell lung cancer and other high neuroendocrine tumor cells, and it's considered a bispecific T-cell engager. We now have new T-cell engagers in this setting, like obrixtamig, and we now have trispecific T-cell engagers, like gocatamig. As you can see here, it binds not only to TCR and DLL3, but also to albumin to increase the half-life of the molecule. And we also have now biparatopic trispecific T-cell engagers, like alveltamig, which binds to two distinct antigenic epitopes of DLL3 on the same molecule, and this increases the selectivity of the target. So what are the strategies to tackle this chemo resistance in the second-line setting? Of course, T-cell engager monotherapy is one of those strategies, and I don't need to spend much time on Delphi 304, which is well known, presented at ASCO last year by Dr. Rudin, demonstrating that tarlatamab monotherapy used in the second-line setting after chemotherapy plus or minus an immune checkpoint inhibitor, compared to standard chemotherapy comprising either topotecan or amrubicin or lurbinectedin, conferred a significant survival benefit for the first time exceeding 1 year. You can see 13.6 months, and this starts from the start of the second-line treatment. So this is really an important achievement. And as we learned more recently in last ESMO, this benefit seems to be independent from chemotherapy-free interval, which is clinically relevant, especially for our patients with platinum-resistant disease who have very limited treatment options in the second-line setting. And tarlatamab benefit also seems to be independent of the use of prior immune checkpoint inhibitors, and this was a concern, another question that was answered by this study. So what about DLL3? Have we abandoned DLL3 as a biomarker for T-cell engagers? This very nice publication just a few weeks ago in Cancer Discovery from the Boston team shows that we can evaluate by immunohistochemistry DLL3 expression on CT cells. And although there is substantial heterogeneity, we can still divide. I'm sorry, but this, I don't think it works. We can divide between DLL3 positive and DLL3 negative immunostained CTC circulating tumor cells, and we can see that if you have a high baseline DLL3 expression on CTCs, which are abundant in small cell lung cancer patients, those patients have a higher likelihood to experience response and to derive clinical benefit from tarlatamab with a sensitivity of 85% and a specificity of 100%. Of course, limited number of patients, only 20 patients, but this is a proof of concept study. And as you can see in this case on the lower left hand on your slide, a case of a patient that started with 100% positive DLL3 expression on CTCs, and at the time of resistance to tarlatamab and disease progression, the CTCs had 0% DLL3 positive immunohistochemical expression, showing that loss of DLL3 expression on CTCs can be a biomarker of resistance to tarlatamab. So we have other T-cell engagers, trispecific T-cell engager, gocatamine, producing nice data from the phase 1/2 trial. Collectively, in the dose optimization cohorts, 39–40% of responses, and gocatamine is currently evaluated in a phase 3 trial in the second-line setting versus treatment of choice by the physician. And the third one, alveltamig, which is the biparatopic trispecific ADC, also very nice data in the second-line setting in the phase 2. It seems that the 10 milligram every 2 weeks is the dose to move forward, and currently the phase 3 study is also ongoing in this setting. How about the combination of T-cell engagers with chemotherapy in patients with relapsed disease? We have some early data in the second-line setting by the phase 1b DARION-9 trial, evaluating the combination of obrixtamig plus topotecan in patients second-line and beyond. You can see confirmed objective responses reaching up to 70%. This is really important, but in my opinion, this combination is not for every patient in the second-line patient. Remember, those patients tend to be frail, pre-treated, and not in very good PS, not tolerating very well second-line chemotherapy, especially in combination, but it certainly is an option for fit patients, and there is an ongoing phase 3 trial, the DARION-Lung02 trial. What about the combination of lurbinectedin plus immune checkpoint inhibitors? In my opinion, this strategy will attenuate as the time goes by, because lurbinectedin is now increasingly used in the first-line setting as maintenance treatment after the results of IM40 trial, but still we have some nice data from the phase 1b2 Looper trial led by Antonio Calles, who is here, showing nice responses, better responses in chemosensitive relapsed patients, as expected, and there is an ongoing randomized phase 2 trial, the LURBIMMUNE trial, with a combination of lurbi plus durvalumab, randomized phase 2 compared to carboplatin etoposide as a control arm. And of course, for the last part of my talk, the new kids on the block, antibody-drug conjugates. We're glad to say that today we have 4 clinically relevant molecular targets for ADCs in small cell lung cancer. We have, of course, B7H3, which is an immune checkpoint. We have certainly DLL3. We have TROP2, which is also evaluated in non-small cell, and the seizure-related homolog 6, which is a neuronal protein produced during embryonal development, but still is preserved in adult CNS tissues and is almost exclusively expressed in adult CNS tissues, but also in high-grade neuroendocrine malignancies. So this is just a busy slide to illustrate the timeline of development of ADCs in small cell lung cancer. It's not a recent story. It's 8 years now that we had the first trials. And this is just to show that for each one of the targets, we have a number of ADCs that is currently under early or late clinical development. And for the sake of time, I will show just some illustrative examples. We have now ADCs targeting DLL3. The first one was ZL1310 from Zai Lab, the big Chinese biotech company, producing really nice data. If you focus on patients exclusively on the second-line setting, oh, it's here. I found the cursor. Here, so you can see 67% responses in patients exclusively on the second line, and this is much better than what we get with T-cell engagers, but we have to see whether the duration is also thus good, thus promising, and this drug is currently under phase 3 trial against physician's treatment of choice in the second-line setting. What about B7H3? We have a number of molecules, ifinatamab deruxtecan, you know very well, promising data in the phase 2 setting. If you focus on second line, you have a median PFS 5 months, median overall survival 10.3 months, and the ongoing phase 3 trial, the ID8-Lung02 trial, is currently ongoing, but there were some concerns regarding the incidence of ILD in those patients, especially those having received prior irradiation for limited stage disease. And to my knowledge, the trial was temporarily halted, at least in Europe, and all sites had to be retrained for the early identification and management of ILD, and now the trial is resuming again, also in Europe, but ILD still remains a concern, and we're waiting for more mature data. Another B7-H3 targeting ADC is HS293, recently acquired by GSK after the very compelling evidence of the phase 1 trial, showing responses more than 60% of patients. And this drug is also in phase 3 currently, actively recruiting versus topotecan, and we're waiting for the readout of many of those trials in 2026. And another drug is YL201, initially developed by MediLink Therapeutics. All of those ADCs have a topo-1 payload with a drug-to-antibody ratio ranging from 3:4 to 8. Very nice, compelling data from phase 2, 64% objective responses, and importantly, this ADC is co-developed with tarlatamab, both in pre-treated patients and in the first-line setting, as you will hear later on from Stephen. And in the second-line setting, we have this monotherapy phase 3 trial, YL201 versus topotecan, which is currently ongoing. But importantly, YL201 is also tested in combinations with either tarlatamab plus or minus an immune checkpoint inhibitor, and you can see early the design of the Delphi 310 trial, which evaluates different cohorts and combination. You can also see here that there is a triplet combination with tarlatamab, YL201, and atezolizumab or durvalumab, and this trial is currently in the dose identification phase, and dose expansion will follow after the optimal doses have been identified. So you can see that it is a very active and hot area of investigation. Currently, the ADCs targeting B7-H3, and unfortunately there is no time to mention all of them. But we also have TROP2 targeting antibodies. Sacituzumab govitecan had promising phase 2 data, not that impressive, I would say, objective responses in approximately 40 to 45% of patients, but there is currently the ongoing EVOKE-04 trial, ongoing in the second-line setting with a comparator arm of topotecan. This trial might read out within 2026. And last but not least, we have the seizure-related homolog 6, which is a target for ABBV706, an ADC that is targeting CES6 and has a payload of topo-1 and a drug-to-antibody ratio of 6. We have two dose levels, 1.8 and 2.5 milligram per kg, that are currently being evaluated. Very compelling data from the phase 2 study, very nice objective responses. And apart from second line, this drug is also evaluated in the first line setting. You will hear later on from Stephen. But still, I want to point out that even in relapsed patients, and you can see what was striking to me, that even in patients with chemorefractory disease, okay. Oh. I don't know what else is going to happen today. Keep calm, small cell lung cancer is difficult to manage. Okay. So you can see that even in chemorefractory patients with a chemotherapy-free interval of less than 30 days, you still get objective responses in half of patients by the use of ADC monotherapy. This is a proof of concept that ADCs and chemotherapy are not the same thing, at least in some settings. And last but not least, of course, we have the bispecifics. We know that small cell lung cancer cells express highly both EGFR and HER3. Isabren, we know that very well from EGFR-positive non-small cell lung cancer, has achieved some impressive responses, reaching up to 3 out of 4 patients in the second-line setting, some heavily pretreated patients, and an impressive median overall survival reaching up to 15 months in pre-treated patients, so we're waiting to see more data on this fascinating molecule. And the future seems to be here. In 2025, we had the phase 1b data from CAR T cells. It was reassuring to see that there were no increased side effects in terms of CRS and ICANS. Actually, the incidence of ICANS and CRS was lower compared to what we see with T-cell engagers, but as you can see, modest objective responses from this first 1B trial, but still this is in clinical development. I'm waiting for more data. I have spoken with Ben Creelan. He's very optimistic about the future of these CAR T cells. And the newest kids on the block, radiopharmaceutical therapies. We have two main components in clinical development today. They both have actinium-225 as the radioligand, the active radioactive substance, which is an alpha-emitting radionuclide, so a proton-emitting radionuclide. The first one binds to somatostatin receptor 2, and the second one binds to DLL3. Both radionuclides have presented phase 1B data in 2025, and we are expecting to see their use in a more advanced clinical setting. These are my last two slides. This is where the small cell lung cancer guidelines were in 2021. I can tell you that they are currently being revised, and if Dr. Popat is here, he can confirm that. And as you can see, we did not have many options. It was a therapeutic desert, the relapsed disease setting for small cell lung cancer. So hopefully, maybe in 2 years from now, the algorithm might look something like this. So we have already T-cell engagers in place. Tarlatamab is already approved and is currently in clinical practice, at least approved in the United States. We're still awaiting for the approval in Europe. And you also have the advent of combinations, ADCs, combinations of immune checkpoint inhibitors with ADCs and also lurbinectedin. And bispecifics are also following, so this is a continuously growing and evolving therapeutic landscape, and hopefully we will have many options for our patients in the coming years. Thank you so much for your kind attention.